last speaker of our morning panel is J.P. Onnela. J.P. is an associate professor of biostatistics at the Harvard Chan School and is also director of our Master's in Science and Health Data Sciences program. He is the recipient of a Fulbright Scholarship as well as the New Innovator Award for his work in digital phenotyping that we'll hear about today. And whether you wear a wearable device or you use an iPhone, he's thought deeply how to mine this data effectively to think about a variety of problems and questions that concern health and social networks. Thanks, JP.
Thank you. Is the clicker here? Oh, yes, here, perfect. Well, thank you so much for having me, and congratulations on this new cancer center. So I wanted to take, maybe we can get to the slides. Let's see. Ooh. Let's go one back. So I want to talk about something that we've been calling over the past few years digital phenotyping. And my talk is going to be a lot less biological and a lot less clinical than the previous talks. But the point of the idea, the gist of the talk is that rather than trying to think about introducing new technology that will create new or generate new data, the question we're trying to ask and answer is, can we use existing technology, potentially at scale, to better capture the kinds of signs and signals that your body is readily giving to you? I'll talk first most about the big picture, and then towards the end, I will try to give a flavor of a couple of potential applications of this approach in the setting of cancer. So I really want to take a couple of steps back and think about the big picture. So arguably, progress in science has always been driven by the availability of data. But something remarkable has happened over the past 10 or 15 years. And I think that it's not only the case that we have more data than we ever had before, but we've had the new kinds of data, especially about social and behavioral interactions that we've never had in the past. So what does this then go back to? So I was worried that somebody else might show this plot, so I'm actually kind of happy that nobody else did. So this is the famous Moore's law. So we're looking at time starting from 1970. On the y-axis, we have on a log scale the number of transistors that can be packaged on a single chip. And what we see from here is that the number of transistors has grown exponentially over the past 4 decades or so. And from our point of view, this has at least 2 important implications. The first implication is that this means that we can manufacture sensors, so we can collect data in completely new settings. The second important implication is that having all these millions and billions of data points, we actually need computational tools and computing tools to make sense of them. So the second important implication of Moore's law is that we can do increasingly cloud-based data analysis of all of these new data sets that we can now capture. So I wanted to I'll be talking about cell phones or smartphones, as I suppose already given away in the introduction. So I wanted to just mention a couple of what I think are kind of incredible statistics. So everybody here has a smartphone, or at least a cell phone. I know one person who doesn't have a smartphone, but almost everybody here must have a cell phone. So the history of this technology is incredibly interesting if you care about technology. So in the world, in 2015, there were 3.2 billion smartphone subscriptions in the world, so globally. And by end of 2022, the expected number is 6.3 billion. So these are amazingly high numbers. If we look at smartphone ownership in the United States alone, in 2011, 35% of US adults had a smartphone. In 2017, the number was 77%, and by now it must be somewhere around 85%. So we started using cell phone data about 12 years ago, first in the form of CDRs, so-called detailed records, to study human behavior broadly. And of course, what has happened in the past few years is that mHealth has become kind of big. It seems like everybody's doing mHealth nowadays. But what I want to talk about is what are the opportunities that this new technology then creates for us. So if smartphones are the technology, then what is the problem that we're trying to solve with that technology? So this is something that we and many others allude to as the phenotyping problem. So if we think about kind of more typical phenotypes like imaging and transcriptomics, social and behavioral and cognitive markers have traditionally been especially difficult to capture because of their temporal dependence and their context dependence. So what we need in our view, is a scalable way to measure and quantify these markers outside of a lab and clinical settings. So as part of our work in this area, we've coined this term that we call digital phenotyping. And there are a couple of other similar sounding terms out there. Our definition for this is the moment-by-moment quantification of the individual level human phenotype in situ in the wild using data from personal digital devices, in particular smartphones. And we think that using smartphones has at least a couple of important advantages compared to things like wearables. So one is that this technology, smartphones, are already very prevalent. The second point is that if we primarily rely on passive data, data generated by smartphone sensors and logs, we can potentially follow people for years and years. And this is a completely unobtrusive way of monitoring people. They don't have to do anything for those data to be generated. So we started the digital phenotyping project about 5 or 6 years ago, and I'm very grateful to the NIH for providing the funding for this project. And we had a threefold goal. First, we wanted to build technology or infrastructure for collecting data at scale. The second goal, which is really our primary goal, is to try to develop statistical and machine learning methods for making sense of these millions and billions of data points that we collect per person per month. And our third goal was to run a bunch of studies across different fields, primarily in central nervous system disorders, but also in cancer, to basically deploy this technology in actual settings, in clinical settings. So the overall goal for us has been to systematize data collection and data analysis in smartphone-based digital phenotyping. So let me say a couple of words about the technology that we've developed over the past few years. So we've developed something that we call the Biwi Research Platform. Biwi is the name of a Nordic goddess for sunlight and mental health. And she's not so in anymore, but she was around apparently about 3,000 years ago. And so the Biwi front end consists of 2 native applications, one for Android devices and the other one for iOS devices. And the whole sole goal of these applications is just to collect very high research-grade data from sensors and logs. So the distinction between a sensor and a log is GPS is an example of a sensor. Something like communication logs are logs which are collected regardless on your phone. Our backend system sits on AWS. So like most people, we use cloud-based computing. And we make use a lot of their proprietary technologies to make sure that the system is scalable. Because we collect the raw data, we get about 1 gigabyte, so about 1 billion data points per subject per month. So the computational model is that rather than trying to download all the data, we try to do the analysis where the data sits. And as part of the backend system, we also have, for example, a web interface that enables us to manage studies and so on. We've also built something that we call the data analysis pipeline, which integrates data from multiple streams and tries to make sense of the data that we've collected. So what does the workflow on the platform look like? Well, we can set up a study fairly quickly. It only takes my RA about 10 or 15 minutes. So she generates a bunch of user IDs and a bunch of temporary passwords. We approach a number of patients, whatever the clinic happens to be, and they download the Biwi app on their personal smartphone. It's very important that it's their own personal smartphone and not a study device, and we can talk about that later if you're interested. They put in the username and the password, and the system automatically connects them with the right study in the system. So they have the right kind of data collection settings, they get the right surveys, and so on. And that's kind of the starting point of how this thing flows. We divide all data into 2 categories, active data and passive data. So active data is simply data that requires some input on the side of the subject to be generated. So this is things like doing simple surveys, maybe giving audio samples, which are, for example, highly prognostic for, you can look for vocal markers of depression and so on. We can do some image capture, and you can do some simple cognitive tests on the phone. On the passive data side, we can collect GPS data, accelerometer data, gyroscope data, communication logs, and all other kinds of data streams. And I'll try to illustrate in the following why this actually might be helpful for our setting. This might be a little bit small for you to see, but the idea is this is open source software, by the way. So anyone who wants to use this anywhere is welcome to do so. We have a web page, like in a web portal, view into the back end, and we can customize what kind of data is collected. So for example, if you care about GPS data, you can click the GPS button over here, and then you specify on the right here what is the duration of your on-cycle and off-cycle. On-cycle is the time period when the sensor is sampled, and off-cycle is the period when the sensor is sleeping. And the reason you have to put the sensor to sleep occasionally is to conserve battery power. So if you've ever tried this experiment, if you sample GPS data continuously, it will kill your phone battery, even if you have the latest and greatest phone, in about 90 minutes. So you definitely have to sample, especially GPS. Then these data are coming in continuously, so it's a high volume kind of data. And it's very high dimensional data. So we typically summarize these data at the daily level using about 100 or so different summary statistics. So for example, from the GPS, we can learn every day what is the estimated amount of time that the person spent at home. From the gyro data and accelerometer data, we can try to estimate number of steps and things like this. From the communication logs, we can learn how many people does this person have in his or her social network. Is that social network shrinking in time, or is it growing over time? How reciprocal are these individuals in their social interactions? We can also learn about things like sleep. As you can probably guess looking at this list over here, some of these summaries are very simple descriptive summaries. Others, like the idea of onset and offset of sleep, is heavily based on modeling. So let me talk a little bit about the potential connections between digital phenotyping and cancer prevention. Like I mentioned at the beginning, most of my work is not in cancer, but we have 2 small pilot studies that are in this setting. But beyond that, I would just really like to give you a potential flavor of what it might be possible to do using this approach in cancer prevention, especially at a global scale. So one idea is that it's traditionally very difficult to capture lifestyles and behaviors. And I forget who first said this, but the basic problem is that you cannot manage something if you cannot measure that. So we can measure weight, so we can think about interventions that affect a person's weight. We can measure blood pressure and so on, but for most behaviors, we don't have very good ways of measuring them. The second idea is that we might be able to identify individuals based on individuals who might be at high risk. So one idea here is that I will talk you through quickly is the idea that we can potentially monitor individual spatial locations, not just for days and months or weeks, but for years. And then based on that data, you might be able to quantify their exposure to things like, nanoparticles or green spaces, which might reduce their stress level, and so on. And finally, I'll just give a couple of ideas about how it might be possible to use this approach to help individuals make better treatment decisions and also monitor their response to ongoing treatment. So let me start from the first part, which is physical activity and sleep. These are the 2 things that we've been working on over the past few years with some of my postdocs and students. So this is tricky, I see now. All right, so let's look at 2 different kinds of sensors on the phone. All smartphones today have an accelerometer, which measures linear acceleration in 3 different directions. Also, almost all smartphones today have gyroscopes, so they measure angular velocity around 3 different axes. And we have here on the left and right a very simple 10 seconds or something sample of data from the accelerometer and from the gyroscope, just to give you a sense of what these data might look like in practice. So working with one of my postdocs, Emily Huang, who is, by the way, on the job market right now, and she's absolutely fabulous. We've been working on this method for how do we quantify physical activity in situ. We did not want to introduce extra wearables and extra sensors. We're trying to think about how can we use this technology that almost everybody already has to learn about their physical activity. So we did a very small pilot study. In this case, we did add extra instrumentation because this is a controlled setting. So we want to really know what these people are doing. So we bought a couple of extra wearables. So we had 2 wrist wearables that the test subjects were carrying. We had 1 ankle wearable that they were wearing. They followed a protocol. They were walking around the Longwood campus. And Emily was also videotaping these individuals. So pretty heavy instrumentation. These individuals also had 2 smartphones on them, one in their front pocket of their pants and one in the back pocket. And so we wanted to understand what kind of data do we get from these devices? Does it matter if the device is in the front or in the back? How well does it work for somebody, for one person versus another? So this is just, again, to give, this is all ongoing work, so I just want to give you the flavor of this. So here we're looking at data for one single test subject for 4 minutes. We have videotaped them, and they follow the protocol, so we know exactly what kind of physical activity they're engaged in. So we know that first they're walking, just flat. Then they go upstairs, going upstairs. Then they're standing still, not moving too much. And then they come down the stairs. So this is the ground truth. So the first thing we tried to do was using accelerometer data for this. So this is the truth, and this is our prediction. And the prediction is okay, but it's not too great. But remember, this is a very difficult problem because the phone keeps moving around as you're doing different kinds of physical activity. The basic idea, I'm not talking about the methods at all, we're essentially doing some type of pattern matching. We're using a dictionary-based method, but that again is a detail. But so the conclusion is here, we can learn something, but it's not too great. Then let's tweak the method a little bit, and let's go from accelerometer data to gyroscope data. And now this is again the truth, and this is our prediction. Now we can capture about, this is just one person, but just eyeballing it, it's almost perfectly capturing what that person is doing. Now remember, this is all passive. So in this case, we happen to know exactly what they're doing. But we could take this and roll it out in a very large cohort, and the person doesn't have to do anything except a one-time installation of the app. And depending on the person, that will take between 30 seconds and maybe 10 minutes, or something like that. But it's very quick. So this is the idea. We can quantify physical mobility in situ. Then sleep is one thing that I think we all could have used a little bit more maybe last night. So sleep was this other thing that we really wanted to learn how to quantify using this approach. And this is based on a study done with Randy Buckner's group. Randy is a well-known neuroscientist. And we recruited a bunch of Harvard undergrad students. This is not the most representative cohort, but this was our starting point. And we asked them to wear these Philips Active Watches, these wearables, for 9 months or so. And the goal was, these are new students who are coming into the university. And we know that there are many social and academic transitions that occur once people leave their homes, some of them for the first time, and they come to a university setting. So we wanted to learn about their behavioral changes. How do they adapt to stressful events like midterms and things like that? So this is data for one person, just randomly picked person, for the first 100 days of the study. We lost some of the resolution in the keynote conversion, so apologies about that. Let me just walk you through what we're looking at here. So this data for one person for the first 100 days. This is day 1, day 20, and day 60. What we have on the y-axis is a 24-hour clock. So this line here is midnight. This is probably noon and so on. Actually, can't be noon. This is probably midnight, 6 a.m. and noon and so on. And the black line tells you that the person is asleep, right? So you follow, let's pick one day over here. On day 1, the person fell asleep on that day at this time, and they woke up on that day at the time given over here. So the idea is if you get to have a person wear a wearable, which is, again, difficult in the long run, you can learn about their sleep patterns and behavior. The next thing we did also, these individuals had the BW app running on their phone. And what we're showing here is the same exact plot for the same exact person. But in this case, we have a blue dot, which indicates that we're getting a certain type of data stream from that person. Can somebody guess what that data stream is? What's that? Sound. Very close. That's right. So a variant of that, which is that the screen of their phone is active at that point in time. We know that apparently all of us spend 6 hours a day on our phones or something. I don't know if that's quite accurate, but whenever we have a blue dot over here, the screen of the phone is on. And now when we juxtapose these two, the intuition is clear. So the idea is, on any given day, we would expect to see a lot of screen on activity throughout the day, and the screen should be essentially off throughout the night, and then when the person wakes up, now the screen activity starts again. Sometimes you will have some activity through the night because maybe you get a notification or maybe you get a text message, but now you can see what the statistical problem is. You pick any single day, and you try to estimate an interval, the start point and the end point, when you transition from high activity to low activity, and then from low activity again back to high activity. This is a method that we studied in the Harvard undergrad cohort. And we also have 150 people who are HIV positive that we're studying in a cohort that's based in Philadelphia. And in both of these cohorts, we have the wearable data, and we treat that as our ground truth. So let me talk a little bit about quantifying risk, which was the second area that I was hoping to talk a little bit about. So I think almost everybody knows what a GPS is. So it's this global positioning system that's used for both scientific and societal applications. But there's also a small but growing number of examples of GPS use in medicine. One example is tracking patients after recovery to understand how mobile these individuals are. But it turns out that there are at least two downsides for using this technology in a research setting. And one of them is that GPS consumes a lot of power, so it kills your battery pretty quickly. The other one is that it takes time to identify 4 satellites. So the GPS has to identify 4 satellites before you can pinpoint your location on Earth. And as a consequence, we need to sample GPS. We cannot collect the data continuously. And the second limitation is that the on period has to be sufficiently long. Now, some missing data problems may seem like, will this give you a benefit of 2% or 5% or something like that? It turns out, if you ignore the missing data problem, the daily summary statistics you use to quantify the person's behavior can be off by as much as a factor of 10 if you ignore the missingness. So in this setting, you certainly cannot ignore the fact that your data are missing. So most applications of GPS that we have seen in the literature either use dedicated devices to collect GPS data, then you don't have the missing data problem. You have the scalability problem, though. Now you're asking individuals to carry these additional devices, and you have to think about how is this going to scale for hundreds of thousands of people or potentially over multiple years. The other approach that we have seen in the literature is people make use of smartphone GPS data, but they ignore the missingness. And this leads to all kinds of problems. So what we try to do is to use smartphone GPS data and then think about statistical problem of how do we best impute the missing trajectories. I'm not going to talk about the details because I was told not to use any equations in this talk, but I just want to try to give you the flavor. So this is data for one test subject. So this is a Monday and this is a Tuesday. In this case, we have continuous data. So we have these trajectories people are moving, and we can divide their behavior into 2 different kinds of events. We can have pauses, which is when the person is not moving, and we can have flights when the person is moving in a constant direction. So what we do is we use circles to represent pauses, and we use lines to represent those flights. And also we color code everything. So dark red means midday, dark blue means midnight. And the size of the circle is proportional to the length, the duration of the pause. So for example, here, this is the location of the person's home. They spend a lot of time at their home, which is fair enough. Then they come to work. This is the location of the Harvard Chan School of Public Health. Then you can see like around midday or 1 p.m. they seem to go somewhere. Perhaps they go out and get a coffee or lunch. And then they go back home. You can't tell this from the data, but I know that this person also has a dog. So she took her dog on a walk that night. You never lose a grad student when you have this approach. You can track your students perfectly. This is Monday and Tuesday. So very similar trajectories, right? The behavioral pattern is almost identical. Then when we go to Saturday and Sunday, everything is the same. Scale is the same, color coding is the same. The trajectories look very, very different. The point is not to make trivial statements like people behave differently on a weekday versus a weekend day. But the point is that imagine if this is somebody who is undergoing treatment and they develop some kind of a complication. they're less able to move, they might stay in their home the whole day or just move around their house just a little bit, a couple of blocks. If they get better, their mobility might increase, and you might see these more extensive mobility trajectories. So then the question is, well, in practice, we'd like to see this, but what we end up seeing is this. So we really just have a very spotty coverage, and we have a lot of missing data. What we can do is we can use this imputation approach that will not be described in any detail, and we can try to impute these missing trajectories. And we actually don't even care so much about those trajectories themselves, but we care more about making sure that the summary statistics that we calculate on a daily level, that those can be estimated without substantial error after we've done the imputation. And in practice, this approach works pretty well. And you can read it. We've published just a paper about this method in Journal of Biostatistics if you'd like to know more about the details. Let me just then try to explain how this might potentially be relevant for something like cancer. This is data for about 3 months for one particular person. And we put a dot whenever we see a person at that location, and we use the color coding to try to convey the idea of how many observations we've recorded for that person at that location. And the idea is that one way, if you wanted to measure individual level exposure, you could instrument individuals with measuring devices. The alternative would be to say that let's have a few devices, as we commonly have, which are located at specific fixed locations. And then we can try to estimate individual level exposure based on how long these people spend at different places. And so then it becomes a mathematical or statistical problem. And again, if you follow a person for years and years, you might be able to get a reasonably good estimate of what was their exposure to X or Y or Z, depending on what is the specific exposure that you might care about. I think I have about 4 minutes left, and we're perfect in time, don't worry. So then I want to talk a little bit about the third thing, which was the idea of how can we use this approach potentially to monitor treatment response. And I'm going to skip in the interest of time, I'm going to skip the first example and focus on the second one, which I think is a little bit more concrete. So this is a study that we did with Dr. Alexi Wright. She's based at the Dana-Farber Cancer Institute. And this is a pilot study of 10 patients who have gynecologic cancers, and they're receiving palliative chemotherapy. And what we're doing here is, in this plot over here, we're plotting their step count for 3 days. It's randomly chosen, essentially randomly chosen 3 days. And what we see is that this person, she doesn't walk too much, but every night she seems to go on a walk, right? You see these well-defined peaks. What happens next is she develops a complication. And we're looking at the data. So this is one of the few studies where we do an online intervention, online meaning almost in real time. So we're looking at the data for day 1, and we see that something's wrong. This person is not behaving they normally do. So what happens is that this person, she developed nausea and started vomiting in the evening of day 1. That's visible in the peak. She's not moving the way she normally would be. On day 2, her steps become undetectable, and she was planning on going to the emergency department. And the fact that we were able to pick up this behavioral anomaly means that in this case, we were able to have a clinical intervention. So this person was contacted by our research staff, and what turned out to be the case was she had a chronic small bowel obstruction and a venting gastric tube, and she was instructed to open the tube. She did not have to leave her home. She did not have to come in. And it turns out that her symptoms resolved essentially completely within 24 hours. So you can see this is when the complications start. So they're all called day 1, 2, 3, but they refer to different sets of days. So day 1, we can see that this is where she starts showing symptoms first, and this is when she develops this complication. And by the evening of day 3, you see her step count hits 2,000 steps. So on day 3, she's able to go on her usual walk. So the idea is, just to conclude some of this talk, so the idea is that passive monitoring of social and behavioral and cognitive markers using passive data is potentially promising, especially for cancer. I think what we really need is the technology alone is not enough. We need the methods, the statistical methods, the machine learning methods for taking these billions and billions of data points and try to make sense of those data. The reason I'm especially excited about smartphones is because the ubiquity of this technology means that if we can develop something here in Cambridge, Massachusetts, or Cambridge, UK, we can potentially deploy this almost at a global scale. There are lots and lots of open questions, and hopefully we can tackle some of these questions as part of the new Cancer Center. But these early results seem fairly promising to us. So thank you very much.